Gregg Stone from the American College of Cardiology in Atlanta, Georgia, where I just presented the results of the RELIEVE-HF trial as a late-breaking trial. And this was a very exciting study that a lot of people were waiting for. As you know, in patients with heart failure, increased left atrial pressure is what causes pulmonary venous congestion, shortness of breath, and leads to heart failure hospitalization in the majority of patients. And the concept has been around for many years that a small interatrial communication between the left atrium and the right atrium could offload blood from the left to the right heart and therefore decrease left atrial pressure and improve symptoms and perhaps prognosis in heart failure patients, regardless of whether they have reduced or preserved left ventricular ejection fraction. So in the RELIEVE-HF study, which was the pivotal approval study in the United States for a very particular type of interatrial shunt, the Ventura interatrial shunt device, we studied the safety and effectiveness of this shunt. And this is an hourglass-shaped device. It's about the size of a dime. It's placed in the fossa ovalis in the interatrial septum through a non-complex interventional cardiology procedure. And it has a central orifice of around 5.1 millimeters, which allows approximately 1 liter per minute blood flow from the left atrium into the right atrium when the left atrial pressure is increased. And the beauty of this concept is that it's really an autoregulatory mechanism that's active 7/24/365. That is, when the left atrial pressure is low, there's not much shunting. When the left atrial pressure rises, for example, during exercise or after a salt load, then there's more shunting. So it should equilibrate the left atrial pressure. So we randomized 508 patients with heart failure with any left ventricular ejection fraction in a placebo procedure-controlled double-blind trial. So half the patients got the shunt, and the other half of the patients were blinded, and they had a sham procedure because they were in the cath lab having, in most cases, transesophageal echocardiography for evaluation, and they were heavily sedated, they were masked, and they and their families and all physicians and healthcare assessors after the patients left the cath lab were blinded to randomization allocation. And because we didn't know whether the outcomes would be similar in patients with reduced ejection fraction versus preserved ejection fraction, because those patients all have elevated left atrial pressure, but the structure and function of the heart is very different, we stratified the randomization into reduced and preserved left ventricular ejection fraction using a 40% LVEF cutoff by core lab transthoracic echocardiography. And that was the only major subgroup in the study. We then followed patients for 2 years until the last patient reached 1 year follow-up. Median follow-up was 22 months. And what we found was that the procedure was extremely safe. There were no device or procedure-related adverse events either at 30 days or at 2 years. However, in the entire population, we also were unable to show effectiveness of the device. We had a hierarchical primary endpoint for effectiveness consisting of 4 cardiovascular events: all-cause death, heart transplant or left ventricular assist device implantation, heart failure hospitalizations, and outpatient worsening heart failure events. And if those were not met, then we looked at improvement in quality of life according to the KCCQ score. And there was no significant difference in any of those elements, whether cardiovascular events or quality of life, between the two groups. Where it became very informative, however, was when we looked at the 2 separate subgroups. The patients with reduced ejection fraction had a marked benefit in outcomes. They were a very high-risk population that were having almost 9 in 10 patients every year having a cardiovascular event, and that event rate was reduced by 45%, p-value less than 0.0001 with the shunt. In contrast, the patients with preserved ejection fraction were a less high-risk group, although they were still high risk, and their adverse event rate was increased by 68% with the shunt. When we looked finally at the quality of life scores, there was a large placebo effect in this trial. All patients felt that they were getting better, whether or not they got the shunt or the placebo procedure, and to an equivalent degree, regardless of whether their ejection fraction was reduced or preserved. So why were the results so different? in the reduced and preserved ejection fraction? Very simply, we had baseline and 1-year echoes, and what they demonstrated was that in reduced ejection fraction, the heart was more compliant and could tolerate the increased blood flow into the right heart from the left, whereas in preserved ejection fraction, the heart was much smaller, much stiffer, that is less compliant, and increased blood flow led to an enlarged right ventricle, increased pulmonary pressures, and decreased cardiac output. So in conclusion, and in summary, implantation of the Ventura intraatrial shunt device in patients with heart failure was very safe, but did not decrease the incidence of adverse cardiovascular events or improve quality of life across the entire spectrum of left ventricular ejection fraction. However, in patients with reduced left ventricular ejection fraction, less than or equal to 40%, there was a marked benefit of intraatrial shunt implantation, whereas in patients with preserved left ventricular ejection fraction, we saw evidence of harm. And these data obviously have very important implications for the future of this and additional shunt devices as use of therapy in heart failure.